Our first speaker today is Kelly Cronin, Director, Interoperability for Healthcare Transformation, Office of the National Coordinator, U.S. Department of Health and Human Services. Ms. Cronin serves in this role to coordinate policies, to create and sustain a more connected, value-based healthcare system. Ms. Cronin was the first staff person in the ONC and has held a variety of leadership positions since its inception. She's also been advisor to the Centers for Medicaid and Medicare Services Administration and supported the establishment of the Accountable Care and Learning and Diffusion portfolios in capability maturity model integration. Ladies and gentlemen, please welcome Kelly Cronin.
Good morning, all. It's great to be here. I was very happy to be asked back after being here 2 years ago, particularly understanding that there's been so much progress and a lot of excitement around what's happening now, not only across Michigan, but really nationwide. And we have some new policies and new laws that we're implementing, and I wanted to take the next half hour or so to give you an overview of what is the Department of Health and Human Services at a federal level, what are their priorities, what are we doing to really try to realize interoperability in the healthcare system as a part of an overall transformation effort, and also talk about a few other priority topics for ONC and the administration. So let's see here. Let's figure out how to go. Great, my slides. So just to start with our new, newish Secretary Alex Azar, who is not new to the department for us. He actually was the Deputy Secretary and our General Counsel back in the Bush administration, so he's familiar to many of us who have been there for a while, and also very familiar with not only the value-based care agenda, but also health IT. He was really very involved in the very early days of ONC in establishing our whole agenda. But the current priorities that he has set out is value-based care transformation, and really making a renewed commitment to this. It was clearly a priority in the last couple of administrations, and we've been implementing new laws and a lot of new payment models to experiment and learn from, but there's now a renewed commitment along this journey. Also combating the opioid crisis is clearly a priority across states, but also really at a federal level, and we're doing a lot across federal agencies to double down and do as much as we can to fight that. And bringing down the high cost of prescription drugs is another priority, as is improving access to health insurance and reducing the cost. And really, we know that health IT is an enabler to, or related to all these, but a critical enabler to the top two. We also are in a place where we have, over the last 8 years, realized dramatic improvements in the adoption of certified records, not only across hospitals, where over 96% are using certified electronic health records, but also across physician offices, where 78% nationwide are using certified technology. So the care experience has largely been digitized. So in terms of point-of-care applications, we're capturing a lot of documentation and maintaining those records over time electronically. Now, really the challenge is to continue this journey towards advancing interoperability, because while we've made a lot of federal investments and state investments to advance adoption, and there's been a lot of concerted effort to improve interoperability, particularly in Michigan, we have a long journey, and we're far into this journey, but we still have a big effort in front of us to really get to a much more interoperable and connected healthcare system. And I think we all recognize that the system itself is quite fragmented, and a lot of legacy systems are there. And when we talk about connecting a very complex, siloed set of stakeholders, it's a big effort. And I think we all recognize that we need to double down and work together to get to the next level. So in that spirit, leaders across federal agencies now have launched the My Healthy Data Initiative. This is an administration-wide effort that is really trying to figure out what are all the policies, all the authorities, all of the programs and initiatives that we can focus on that are really going to drive interoperability across the healthcare system. ONC is doing a lot, which I'll be talking about, much of which is enabled through a new law. The 21st Century Cures Act gives us new authorities to implement new policies that will really improve interoperability. CMS has, of course, existing authorities across how they pay for physicians and hospitals and long-term care facilities and how they regulate much of the healthcare system. And we are working collaboratively to really look at how do we move the needle? How do we continue along this journey and really leverage all of their authorities and all their power in the market? And the VA is also playing an important role. They recently did an open API pledge, so the designated apps for both veterans and clinicians within their system, also their partners, so veterans now have the choice to go outside the system to receive care. So everyone along that continuum that's using these designated apps is pledging to open APIs. They also have signed, as many of you might know, a contract with Cerner, and there's a lot of contractual requirements for interoperability built into that. Of course, that very large implementation that will take place over the next several years, we think will have a big positive influence. So I mentioned the 21st Century Cures Act as being an important new law to drive interoperability. Just note that we've always benefited from bipartisan support in the health IT agenda for the last 15 years. And we're still, I think this has really been evidenced by the passage of this law. It was a bipartisan majority that passed the law. They heard a lot from stakeholders over the years about their frustrations with health IT, the lack of usability, the lack of interoperability, and they took a lot of input from a lot of stakeholders in crafting the provisions of this law. And we are now heads down really trying to figure out the best way to implement these provisions. Some of this is going to be through rulemaking. So ONC will be pursuing changes to the certification program, creating new conditions of certification and maintenance of certification. One particularly important provision that we're focusing on is how we ensure that vendors are putting out open APIs. So not just APIs sitting on a closed system, but truly open APIs that can be readily accessed, where there's actually written in the statute that you have to be able to access and use the information through an API without special effort. So how we then specify that in regulation will really put some legs behind the expectations on vendors. So when you heard about the fire test bed and fire pit early this morning, which is really exciting work, that sort of makes it real. It's not just, we have sort of a nice reinforcement of these really great progressive efforts in industry and in stakeholders like what you've witnessed this week, but also there's now this reinforcement in law that this is going to, there's going to be a level of accountability behind it. We're also going to be addressing voluntary certification that meets pediatric needs, which we've heard about a lot over the years. And we're also going to be trying to determine how health information networks will be attesting to a common agreement that will create a trusted exchange across disparate health information networks, which I'll talk more about in a bit. So this path to patient-centered care, we feel APIs are going to play an important role. It's not just that we are trying to be more modern and move into more modern computing standards like the rest of the technology world. Everyone who uses a smartphone knows that it's very much a seamless experience to do many of the things you want to do in your life. It's whether it's scheduling travel or your anything you want to order, it's all fairly seamless now. So we're trying to get healthcare into that more seamless experience that's mediated through open APIs. So we think that FHIR is getting a lot of traction. There's not only been terrific efforts in Michigan, but in Boston, and a whole industry-wide collaborative has really made a lot of progress in recent years, along with HL7, that is organizing a lot of the standards process and balloting process around this. So we know that there's been 3 rounds of implementation, and then there's a new round or a new release of FHIR planned for the end of this year. And there's 55% of certified EHR vendors certified to the 2015 edition, which is our most recent edition, that have this capability now for open APIs through FHIR. And I think many of you might also know that Apple has announced through a pilot, an expanding pilot with many health systems now, that they're using FHIR. Even yesterday, they had a new announcement for an open API that will help search medical records. So that is now open to their developer community. Some of the examples they were giving, that if somebody wants to retrieve their medication lists, the developer can use this open API to get a nice list, a current list of medications on an iPhone or as a part of their Apple kit. So there's really a lot of traction across the standards community, across industry, and we think that our policies are going to be just accelerating this movement. There's another important part of 21st Century Cures Act around information blocking, which really prohibits information blocking, not only among providers, but also among vendors. I think there's been a lot documented in the literature. In fact, some of you who know Julia Adler-Milstein, formerly of University of Michigan, wrote a very nice paper on this, did some important research. That we all know this is a real phenomena, and it does need to be addressed. So it's prohibited now in the law. We are partnering with the HHS Office of Inspector General to implement these provisions. They will be enforcing it. So if a provider or vendor is knowingly trying to prevent or discourage the access and use and exchange of data, then there could be enforcement action taken on them. So if you know of anything like this happening, if you want to be giving feedback on this, we'd encourage you to let us know. And I put the hyperlink at the bottom of this page. If you do want to give us more information about what you're observing in the market or what you think needs to be done. The other thing that also was mentioned earlier that's a part of the 21st Century Cures Act is the Trusted Exchange Framework and Common Agreement. So this is really solidifying what we've been trying to do in different iterations over many years. This was originally done, or tried to be done in the Bush administration, but it's now in law to actually implement this, and it's also really a requirement that ONC partners with the private sector and other federal agencies and government to make this happen. So it's not just ONC or a federal government-driven effort. It's really a partnership in trying to figure out how do we create a trusted exchange framework that all health information networks in this country can be part of. So what are the rules of the road? How do we make sure that there is trusted exchange from network to network that protects privacy, security, but also really fills an important need and creates a vibrant market for these services where we can get to all corners of the country. There's a lot of white space right now that don't have really a lot of exchange options, a lot of providers that don't have exchange options for important use cases in the country. So not only is this sort of a new governance mechanism that will be created through this public-private partnership and a common agreement that health information networks will sign onto and have to abide by, but we also think that it really will help sustain the market if done in an appropriate way. So the law requires us to partner on this. We have already put out a draft trusted exchange framework and got incredible feedback on that. A huge amount of public comments from all stakeholders that we've been processing. And then we will once a common agreement is put forward through a process I'll talk about in a bit, we'll then be publishing that on our website. So I think we all recognize there's a lot of complexity in the market with exchange. There's a lot of different ways that health systems or doctors' offices have to exchange data now, whether it's labs or pharmacy or scripts or images or summary records post-discharge, querying for medication history. There's a lot of different connection points, and a lot of it's point-to-point interfaces. It's complicated to negotiate all those agreements, and it's also costly. We know that point-to-point interfaces and maintaining all them is really not sustainable. I mean, this is all stuff we've known for years, but this opportunity for an exchange framework and a common agreement is going to be addressing this. It's well documented that right now most health systems are supporting many different types of exchange, which also is really burdensome on providers, particularly if it's not single sign-on and really seamless in their workflow, which we know is limiting the adoption of these services. So in terms of goals of the Trusted Exchange Framework, we really want to build on what's already happening in the market, all the productive work that's been done over the last decade or more. We want to ideally build a single sign-on ramp, so it makes it more seamless for providers to access information they need for patient care. This isn't going to be realistic in the next year or two for all use cases, but it's a goal that we really want to keep front and center because it's really important for workflow and for to make this sort of work at scale across use cases. We want it to be scalable across the entire nation, so not just across progressive states like Michigan, but really work nationwide. And we want to be building a competitive market for data services, so not have so much focus on proprietary connections on just moving the data around. That should become more ubiquitous over time. But if there's a more competitive market on how you use the data, so the data services on how do you make the data valuable to the end user. If there can be more of a competitive, vibrant market around that, we think that is really the direction that will be productive for everybody. And of course, we want to achieve long-term sustainability with this whole effort. So what will this look like? How will it come together? So we think it's going to be important to have a recognized coordinating entity that will be sort of the governing body, a multi-stakeholder group that will be actually responsible for creating the common agreement, maintaining the common agreement in partnership with ONC, but it really will be a product of this entity. And also to be able to govern and give oversight over qualified health information networks. So these will be sort of a core number, not an infinite number, but a core number of qualified HINs that will then connect down to other health information networks. So they'll provide a connectivity broker service to all the other QHINs in the market. So there'll be a defined number of QHINs and then health information networks underneath them. So that if you're a provider, let's say you're University of Michigan, and you want to query for the history on patients you're getting out of state, you should be able to go through your let's say it's MyHIN, but it could be any any health information network that is part of a QHIN, and that QHIN then will put a message out to wherever your data might reside out of state, and be able to retrieve that history out of state and bring it back to University of Michigan. So that's sort of functionally how we think it will work. So the recognized coordinating entity will be playing a really important role as the governing body. It's important that it'll be multi-stakeholder. It really will be setting much of the rules of the road. The Trusted Exchange Framework itself will be something that ONC maintains. It's already drafted, and it'll be updating and will maintain over time. But then it's the common agreement that implements that and really gets at a much more granular level in terms of all the expectations that will have to be met by the QHINs and then the HINs that are participating under the QHINs. They'll also be responsible for enforcement or monitoring. So if there's non-compliance with the common agreement, they'll have to be looking at remediation or not allowing for participation among the network of networks if there's noncompliance. So that how all that works will be specified by the RCE. And then the process for recognizing the entity will be done through a competitive, open funding opportunity announcement that we'll be releasing later this year. So organizations that have experience in convening stakeholders in this space who also have implemented these types of governance principles and have practice or experience with that will be eligible, nonprofits as well. And so ONC will be collaborating with this entity to really do all this work, to draft the common agreement and figure out how this is all going to come together. So essentially that trust exchange framework will create sort of a technical and a governance infrastructure that sort of pulls together not only qualified health information networks, but the HINs that are underneath them or part of them. So who can participate in TEFCA? Who will be benefiting from this? It's pretty inclusive. I mean, we're looking at not only all the existing health information networks that would want to sign on and feel they can comply with what a common agreement will look like, but federal agencies, state government, all the programs that could benefit from the retrieving of clinical data to meet your various purposes, payers, obviously providers, technology developers, so whether it's an EHR vendor, an analytics vendor, or a clinical data registry that is maintaining data on a population of patients. They're all potential end users, as well as individuals. We think a really important use case is going to be consumer access to retrieve their own information and having a seamless experience associated with that. So what are the benefits? Why should people care? How is this going to help? Well, the health information networks, again, the example I gave of, many are regional or sort of within one given set of actors. Much of the care experience, as we know, it falls outside of one doctor's office or one health system. So to the extent that many patients have data that resides in many different places in the healthcare system, this will allow for health information networks to get beyond their provider networks, beyond their existing reach, to be able to retrieve a more complete history on the patients and for the providers that they're serving. And also be able to retrieve over time at a population level. There's some new fire standards development in this area that is not quite ripe for real-time implementation in the next year, but we do think in the next 2 to 3 years, there'll be a lot more experience with it, and it'll allow for that population level retrieval. So health systems and ambulatory providers, we really do hope that this creates over time a more seamless experience and gets away from so many point-to-point interfaces that are costly. So being able to retrieve and get longitudinal data on the patients you're serving, we think will be an important value add. And patients and caregivers, right now, many do not have access to their information. They may know about a discharge from a hospital or the experience from one visit, but they don't have the ability to navigate so many different providers, particularly those that are very sick. There isn't an easy way for them to retrieve all their health information, all their up-to-date meds, all the things that are really important for them to understand and be empowered for not only self-care, but to be active participants in their health care. So to complement and also coincide with the trusted exchange framework, we're advancing the U.S. core data for interoperability, and this is really intended to try to have a more systematic approach for all of us, the whole community working in this space, to have similar expectations for a core data set that should be able to be exchanged nationwide whenever it's needed. This is some of the baseline work has been pursued for many years on this. So most of the data you see on this slide, patient name, smoking status, medication allergies, care team members, this is already sort of mainstream in most electronic health records today. So we want to take common clinical data elements that have already been supported by the clinical data architecture, the CCDA document standards, but then build upon that and have an incremental approach to say, an expanding core data set over time will have to be supported by providers, by vendors, and by health information networks that are part of TEFCA. So in order to do that, we want to sort of lay out a roadmap and have different classes of or categories of data that will all be transparent. We'll get a lot of public input, stakeholder input on what are in these different classes and how fast should they graduate to being part of the core US CDI. So for example, many people are quite concerned about psychosocial data and behavioral health data. Right now, we have that considered as sort of a emerging data class. Some vendors have the ability to already implement it, and it's being done for certain clinical settings, but it's not across the country. It's not an expectation supported by certification, for example, or will be a baseline expectation for all health information networks to support. But many people, for very good reasons, think that that's a fundamental part of holistic healthcare. And if we're moving to that model, particularly for high-need vulnerable populations, that should be part of a U.S. core data set. So there'll be a lot of deliberation on how fast we move, how fast and what moves, how fast do we go in family history? There's many other advanced directives, many other important needs that should be, many would argue, part of, right now, a U.S. core data set. But we have to be realistic in knowing that we can't expect everything to happen at once. So this really is the way of laying out the roadmap. So over time, it'll be transparent, year to year, what the expectations are for providers, vendors, and health information networks. So CMS is obviously a really important partner to ONC, and we all know drives the market in many ways with Medicare and Medicaid policies. But they, I would say, are playing an increasingly important role now in this My Healthy Data initiative, and really has very strong, committed leadership to looking at all the things they could do to really advance this. I've been working on this area for a long time and have worked with various CMS administrators, and I just think there's a renewed focus and a level of accountability I haven't seen before, and making sure that a whole set of policies get proposed and finalized. So I think it's something we can all be excited about. So the most recent thing you probably, if anybody who's tracking this, there's been sort of an overhaul and a rebranding of meaningful use, really focusing on promoting interoperability. So this was initially proposed under the Medicare inpatient prospective payment rule, but it's intended to try to simplify the program, reduce the burden, limit the number of measures, promote flexibility, but also require 2015 certification. That's a hard, fast, you have to do it by 2019. We're also exploring things like how do we have interoperability as a part of star ratings, so there's more transparency around what providers are truly interoperable, or what MA plans or managed care organizations have provider networks where the providers are really demonstrating interoperability. So how we do that is part of a lot of ongoing discussion. Another really important authority, really the ultimate stick that CMS has, is what do they require in the way of conditions of participation for hospitals and potentially other institutional providers, but particularly hospitals. So for example, right now there's a whole suite of expectations in law and in regulation and in interpretive guidance the state surveyors use around what do you have to do for admission, discharge, and transfer. There's also requirements that you have to move data after a patient is discharged or transferred. It does not specify right now that you have to do that electronically, but we're seeking input through this IPBS rule and others on should we make that a hard, fast rule? If you're going, as soon as a patient gets discharged or transferred, that information on that patient has to be transmitted electronically if you're going to get any payment from Medicare. So that is really the ultimate stick, and that could be done potentially, in a way that would be implemented over time, but it would make it very, crystal clear in the market that exchange post-discharge, exchange with transfer has to happen if you want to get reimbursed. So BlueButton really is the way that Medicare beneficiaries are accessing their claims information. There's been a lot of progress in updating this, making it more modern, and working with open APIs to have a sort of vibrant set of vendors that are developing to a FHIR-based API, which I'll talk a little bit more in a bit. So just a few more details on how we're revamping meaningful use. Really, there's a commitment to not only simplify this and make it less burdensome, but also make it consistent across hospitals and eligible professionals. So how it's been, how it gets specified over time through the implementation of MACRA or the quality payment program. We really want to have similar framework and expectations across the board. There'll be a 90-day reporting period that'll be consistent for 19 and 20. And then the scoring methodology has changed based on stakeholder input. So it sort of removes the all or none aspect of being successful in attestation. Scores are based on 6 measures. And so the security risk analysis is really just now an expectation or a gateway measure. So a little bit more about BlueButton too. There's really been a lot of uptake across vendors that are building to this new FHIR API. And it has claims data on the 53 million Medicare beneficiaries from a chronic care warehouse. So the data source is pretty impressive in terms of its reach. And it's also allowing for more secure access for the beneficiaries, and it's easier for them to use the data. So not only we're doing a lot to really focus on moving the needle for interoperability across the administration, but we're also working very closely with CMS and other HHS agencies to try to reduce provider burden. In many ways, this is sort of a sister problem to interoperability. There's many aspects of interoperability that do introduce burden, but we are very focused. In fact, it's really required under the 21st Century Cures Act for HHS to put a report back to Congress that'll specify how we're going to reduce provider burden associated with electronic health records, particularly around administrative and reporting requirements, regulatory reporting requirements. So we've had a significant multi-agency, multi-stakeholder effort in the last year, really, trying to figure out how do we do this well? What are the big problems that we need to tackle, particularly around things like documentation requirements and for evaluation and management codes under Medicare. Many people think that that has just created enormous note bloat and makes EHRs not very usable. And then once there's this note bloat, then you have all of that information that isn't always easily accessed, for the specific decision that you're making as a clinician, but it also can make it challenging when you're sharing information from provider to provider. So what actions can we take to improve documentation that's required under regulation, namely and especially the ones associated with the evaluation and management codes? And then what else can we do across our federal programs to address this burden? So we've been looking not only at documentation requirements, but also what are other payment models requiring that could reduce this burden? What are all the quality measurement requirements, not only ECQMs, but really a whole spectrum of reporting that's involves the EHR? How could we be addressing that in a way that's systematic and making it easier for vendors and providers? What are things we could do to improve health IT design and usability? And then what about payers outside of Medicare and Medicaid and other federal payers? What can we do to work with them to reduce burden along with other government requirements? And as many of you know, there's a whole spectrum of public health requirements that, and really for whether it's CDC or on the federal side, there's mental health and community health center reporting, and even USDA, women's, infants, and children. There's many different public health reporting requirements that involve EHR data. They're not all harmonized. They don't all require standards. They don't get the data in a way that leverages modern standards. So there's really a lot we've been looking at to figure out how do we harmonize and streamline that experience to make it easier. So while we've been heads down on that, and I think you can expect to see more and more changes coming out through proposed policies, so stay tuned. It's not just a report to Congress, but the real changes will happen too. But we're a sort of a demonstration of what we're doing in this space through partnerships, particularly with payers, is the Vinci Project, which is really a private sector-led effort among all payers that are committing funds to this to try to leverage FHIR for some priority use cases to help with exchange between providers and payers. Also to help with provider-provider communications, but as an example of one thing they're looking at is with prior authorization, how can that be more, how could there be a development of a FHIR use case and resource that will help with the prior authorization process, which we know is extremely burdensome, particularly given the variation of prior auth policies across payers. But it could be streamlined, and that's an area of a big opportunity. The goal is to really create, a better workflow, to really try to advance these standards and implementation of these standards in a way that's scalable, but really addressing some significant pain points. And then we're also, beyond that, ONC is leading a payer to provider task force, which is a complement to this in that it's looking at what's sort of the highway around this? What are the set of things that we could do to be addressing the identity, authentication, and messaging platform to make this scalable? So not just the FHIR standard itself, but everything around that needs to work to be able to make this a scalable effort across national payers and providers. So these are things that are ongoing, that there's real commitment to. So we are, I think, can look forward to seeing some progress. So what should you be expecting from on the federal end? I think there'll be a lot more changes proposed in regulations, both CMS regulations and in ONC regulations. So stay tuned this year to see things coming out that will be not only advancing interoperability but reducing burden. There's also, as you know, public input processes around that. We really do want to hear from people to make sure we finalize rules that really are addressing these issues in a way that's very workable. We will be funding a recognized coordinating entity to be a partner to implement the TEFCA. And we'll be expecting a draft common agreement the first quarter of next year for public comment. And then we'll also be doing the report to Congress on reducing burden, which we expect to address all the areas that I outlined. So that's a quick overview of sort of everything we're doing on the federal side with respect to interoperability and reducing burden. And I think there might be some time for questions. I don't have a watch on me, but I don't think we're at time yet.
Hi, I'm Dan Boyle. I'm with the Upper Peninsula Health Information Exchange. And first of all, I want to thank you guys for really going towards the standards and the interoperability, and everything that you mentioned here is very exciting to us and something that we've all been looking forward for a long time. And we like that the federal government is helping bring things together, and especially calling out the people who have closed off APIs and now trying to open them up, having a standard of, data delivery, and looking at what is available to make things simpler for providers to do. So my question is, where our main business is in a rural America, a lot of individual providers. And so I see this, I love this, I would like to see this, but I look at all of our little provider offices and how are they going to be able to implement this and take advantage of it and get the resources to do this, because they don't even have the staff to train themselves on what they're doing right now. They rely on other people to come in and help them figure out how to do this and submit their data and things of that nature. So I'm hoping that this plan, this simplification, is geared a little bit more towards those small providers rather than focusing on the big health systems, which really do have a good footprint in this interoperability and health information exchange market. Could you talk a little on that?
Sure, yeah, it's such an important point, and I think we're keenly aware of the challenges of small offices, particularly in rural areas, and I would agree with your assessment that sort of the big players in interoperability to date have been more the large health systems, and they're not only in many cases academic leaders in this space, but they have the resources to really invest in various methods of interoperability. So we are really aware of it. I think that HRSA has funded a lot in the way of community health centers being able to support their EHR implementation and sharing, and that's a commitment that will continue. And I think also under the physician fee schedule, the Medicare physician fee schedule, there's the possibility of addressing needs of the small office in a variety of aspects of what they need to do to coordinate care and have information exchange as a part of that, so that they're adequately reimbursed. If they're not recognized as, sort of, if they're not paid for in an alternative way as a safety net provider. So there are a lot of expectations. I think ultimately TEFCA is trying to get to a single sign-on to make a more seamless experience for small providers in particular. I mean, it's burdensome for an ER doc or a hospital provider, intensivist, anybody who needs historical data right now, unless you are in a unique situation. But I think we're particularly in tune to the needs of the small ambulatory provider. I don't know that we have all the answers right now, but I think it's something that we all need to address as we really get into this next phase of work. I think the other aspect of this is that while we will not be setting prices or fees for QHINs or HINs, we are specifying some parameters around reasonable cost. This is not a for-profit venture where we, want to see any kind of price gouging. We're trying to put some fair, reasonable parameters out there so that there should be services available at a reasonable cost. So anyway, stay tuned, and it'll be really important to have your voice and your perspective as a part of this whole process, so I'd encourage you to stay involved.
Hi, my name is Kathleen Connor, and I'm a co-chair at HL7. I work on FHIR quite a bit, and one of the things that kind of concerns me about the idea that groups of vendors and payers who have to pay a high fee to get together or get there by invite only, and there's two groups in particular, you probably know who I mean, can set the standards for interoperability about how FHIR will be used, basically tailoring it to their systems, and to a certain extent, advantaging themselves in the market. So to me, that's one issue. The other issue is just because they do that does not, and you adopt even Argonaut or any of the FHIR guides that come out of the Vinci Project, does not mean that everyone is actually implementing it the same way. There's too much flexibility. It's not like V2, but there's still a lot of flexibility among the ways in which, excuse me, to implement FHIR. So testing is going to have to be very important, or information blocking will still continue. Thank you.
It's really great comments. I'll take that back to our standards and technology team. And I think we're somewhat aware, particularly of the issue around who participates in standards development, because it's been a long-standing issue in terms of having it largely a voluntary process. So those who are able and have time and the resources to participate do. We've tried to address that in a variety of ways, but it really is an open door policy, and there's only finite federal funds that can support this through our appropriations or through our funding. So there's no sort of instant solution for that issue, but it's something we really need to manage too, and I appreciate the feedback. And the testing, you know, I think is really understood too, and I think just stay tuned in terms of, you know, what ends up developing in that space, but also give us feedback on if we get it right or wrong.
Good morning, Kelly. Tim Pletcher from my hand. Thank you very
Tim.
much for a great overview. Under TEFCA, the US CDI core data sets are really important. My concern when I looked at the progressions, we have a long way to go to sort of specify and sort of accelerate that process, and a lot of things are left out. Is there any particular place we should go, or that you know of, that's really trying to accelerate that conversation and move those timelines a little faster, because they're going to be the rate limiting step for all this interoperability stuff, and it's kind of buried deep in all the documentation.
Yeah, great points. I would say the high tech has been more focused. They had a task force to look at this. This is our Federal Advisory Committee that's been sort of reestablished under the 21st Century Cures Act. And so they had a task force looking at this, but they were mostly focused on the process, trying to get the process down before they really get into the individual data classes and, you know, sort of the deep considerations around what's in and how fast do they move. I would say probably just having that open public discussion through high tech is going to be really important. But also, you know, I would give feedback directly to Steve Posnack and Don Rucker and you know, my colleagues at ONC who are sort of on point for this. So yeah, I would just keep saying these things and give your specific ideas on, you know, what needs to be in, what needs to get done to have them move along more quickly, and how can we do that collaboratively. You know, it's really going to take a big lift on many of these things. So yeah, just put your ideas out there and make sure a lot of people hear them.
Good morning, thank you. Mary Graham from Great Lakes Health Connect. We're a self-supported nonprofit, HIE, here in Michigan. And I wanted to follow up on the comment for the rural, small, single provider offices and the barriers that are presented for interoperability for them. You mentioned that you're going to be looking for price controls for HIEs, and the barriers really are not the HIEs. The costs that we present are either minimal or free to our providers at the individual ambulatory physician level. The barriers are the EHRs. They do not encourage it, and they do not charge in a way that the providers can afford. The projects are very expensive and create barriers for them to do interoperability at all. So it's not the HIEs that need the regulation, it's the EHRs.
Yeah, no, I hear you. And just as a point of clarification, we're not doing any price controls. We don't have authority to do that, and I don't know if that would be the right thing. But we are putting forth parameters around what we think are reasonable costs. So having, you know, cost of goods covered is like a reasonable accounting practice. But that said, anybody participating in the common agreement is going to have to be following some general parameters. So, and if data is being retrieved from EHRs, or EHR vendors are going to play an important role in this whole thing, then they're not going to be able to, they have to abide by the common agreement if they're in. If they're non-compliant, then it'll be up to the RCE to take some remediation steps. So the intention is for everybody to be fair actors and follow the rules that are set and agreed upon. So this should play out over time, but it'll be important to see what's really happening in the market and to understand that.
Kelly, thank you so much for a great presentation. You covered so many things. There was one thing I'm not sure I understood, and I was hoping you could talk a little bit more about when you were sharing upon discharge, requiring provider organizations to share in an interoperable way, that it would somehow become, I'm just curious what authority you were referring to. How would CMS implement that? I'm a policy geek, so.
Sure, yeah. So there are conditions of participation for hospitals and long-term care facilities to be part of the Medicare program to receive any reimbursement. And some high-level parameters around those conditions are set in statute and law, and then they are implemented through regulation and also through interpretive guidance that is put forward to surveyors who are in the field to actually make sure that hospitals or LTPAC facilities are complying with the conditions. So what's being suggested or what we're seeking input on is whether or not we should be revising the conditions of participation that relate to admission, discharge, transfer, particularly around discharge transfer. Should there be an expectation that would extend upon the existing requirement that information be shared with the patient and with the other provider that is treating the patient post-discharge or transfer, but that actually be information shared electronically. So that's what we are suggesting, that there's going to be a move to that. So how that gets done, under what time frame, can it be done for all hospitals? All hospitals, should they be treated equally under this new condition if it were proposed? That's the kind of thing that we want to better understand to inform a new policy or revised policy. Does that make sense? Okay.
Or promote providers, in turn the EMRs that are, the entities that help facilitate that, to support interoperability. So that's definitely the kinds of incentives that I think would increase interoperability around the country.
Good morning, Kelly. Jeff Livesay, Mayan. Thank you for the great overview. Sort of a two-part question on TEFCA. I think when many of us read the draft description of the recognized coordinating entity, we said, wow, that's a lot of power. In fact, we have an affectionate nickname. We call that the Uber Mega King Kong. And so part A of the question is, I think there's, as I talk to national organizations, I think there's concern that if the RCE is one organization, that much power could result in the promotion of that organization's agenda. So that's part A of the question. Is it one organization or is it a multi-stakeholder sort of arrangement? Part B, with respect to the common agreement, if you can share any thoughts about whether that is something that would be based on an existing agreement or the best practices from all the good agreements that are out there, or something entirely new. Thank you.
Great questions. I think that it is going to be really important for whatever recognized coordinating entity is selected for it to be multi-stakeholder and balanced and address the interests of all the parties, which is going to be a very difficult task and will require exceptional skills, for whoever leads that entity. That said, I think, we recognize the challenges that lie ahead, given sort of where the powers lie in industry and market forces. But that's part of having this a public-private partnership. Government's going to be, keeping their eye out for fair and balanced process and have clear expectations around what good governance looks like. So it is a partnership with government for a purpose. And so I think that, we will be trying to make this as collaborative and as functional as possible and not let sort of specific interests dominate. But it's going to be, and really important work, and they will have, very important set of tasks in front of them. But, the public-private partnership, we hope will help sort of sustain a balanced and collaborative approach. And then part two, I'm sorry, if you could just remind me what your second question was.
So for the common agreement,
yeah.
do you think that...
that'd be leveraging existing agreements.
Right.
Yeah, I mean, I think that, one of our goals is to leverage the existing progress in industry. That's not to say that there is one, reciprocal agreement that has been historically developed that would represent all the parameters of what's been put forward and discussed to date with the trusted exchange framework. So I think, we are sort of in a new market, a new day. Some of the things that have been developed historically might have been done several years ago. But we should, leverage all our lessons learned in trying to create something. So I don't think there's a very specific answer to that. I do think we want to learn from and build from everything we've done in the past, but we also need to really try to address all of the various perspectives we've heard this year from people in terms of what's workable and what they think needs to happen, and try to have a functional collaborative process to finalize an agreement. But I do think even just one of the conditions of the RCE is to have experience in sort of implementing these things, so that they have learned and had some practical experience in seeing what does it take to get to governance rules that work. So that there'd be an expectation that would be brought to bear in finalizing an agreement.
Hi, Kelly. Helen Hill from Michigan HIMSS and the MyHIN board. Welcome back to Michigan. It's great to see you again.
Thank you.
My question has to do with TEFCA and the rollout and some of the, and how you would incorporate and build on industry comments to the original rollout of the information on TEFCA. I know there was a lot of feedback from the industry and from HITAC on specific concerns with the overall model and how it would work and what the costs would be and how the flow downs would work and process and so on. And it seems that unlike other periods over the last 10 years, you're not going to go back to the industry for second round of comments. I think I understand that you're going to focus on getting the RCE in place and then the common agreement and then try to deal with some of this. But there are a lot of us who are worried about disruption in the industry, and it would feel better if there were a more public process. And I wonder if you could comment on that.
Yeah, it's a really good question. We have had a lot of internal discussion around that very topic, recognizing the need to be as transparent as possible. And generally speaking, we've had a lot of stakeholder discussions in the last year leading up to where we are today. We also have a timeline, and we have funds that we need to administer in this fiscal year, because that's our budget reality. And we know also that we want to have a public process around a draft common agreement in the first quarter next year. So we are trying to figure out how much can we say when over the next coming months, and have, because it's not just a matter of a couple of people getting together and think, oh, this would make sense, this is reasonable. There's a lot of legal opinions around how we proceed, and so I think we hear you loud and clear, and recognize that the most transparent process possible is probably the best. But we also need to be accomplishing our goals and administering funds. So we're balancing all that to be able to figure out how we can make things happen in the next 9 months or so. Okay, well, I think if that's it for questions, thank you all. Have a great conference.